Thank you so much for taking time out of your busy schedules to join us here. My name is Emma Garrett, and I'm a clinical nurse educator here at St. Paul's Hospital and the director of the Addiction Nursing Fellowship with the BC Centre on Substance Use. So it's nice to see lots of familiar faces and other folks and folks from here and in the community. So I'm really pleased to present Patty Johnson, who is one of our current nursing fellows. So Patty Johnson is an addiction nursing fellow with the BC Centre on Substance Use and is a practicing RN at BC Women's Hospital. She has worked for the past 16 years at First Square, which is EPIC, a perinatal addictions unit that cares for and supports marginalized pregnant women and mothers who struggle with substance use. Compassion, dignity, and creating relationships of trust are the fundamental principles that guide her nursing practice. Through the various clinical placements within the Addiction Nursing Fellowship, Patty hopes to broaden her understanding of the medical and psychosocial challenges faced by people with substance use disorders and to learn more about the resources available. She plans to increase her knowledge of substance use disorders, replacement therapies, non-pharmacological treatments, and ongoing recovery care. In the future, Patty would like to become involved in education and research projects that would assist others in better understanding the challenges facing substance-using clients, with the hope that the misunderstanding and stigma that presently exists will be replaced with advocacy and support. So today's presentation is one of those pieces, so she's already doing it. It's not even the future, it's now. And she's going to present to us today on rooming in, keeping substance-using mothers and their babies together. Join me in welcoming Patty.
Good afternoon and welcome. My biggest challenge will be the computer, I think. Okay, so before I get started, I would like to respectfully acknowledge that I'm a humble guest on the unceded traditional territories of the Musqueam, the Squamish, and the Tsleil-Waututh Nations. And for that, I'm very grateful. I'm going to start my presentation by reading you a letter, and I'll explain it a little more when I'm done. Can you hear me? Is it clear? Is that better? Yes? No? Okay. So this, I'll explain a bit. My beautiful daughter, I promise my life and my soul to provide you with the most unconditional amount of love, of joy, of all the wisdom and knowledge that my body and soul can provide. But most of all, I promise to keep you safe, to put you before anything detrimental or harmful to you in any way, shape, or form. You, my love, are my blessing, and I shall treat you as one. How privileged I am to hold you, my baby girl, to proudly hold my head up high with such pride and honor and gratitude, to be the one to watch and teach you, learn and grow. Words truly can't explain it. So this letter could have been written by any mother, but it was written by one of the women on First Square, one of the substance-using women. And the feet are her baby's feet, and those are her hands. I'm just trying to see what, okay. It'll take me a minute to get my head around this. But anyway, I've worked on fur for about, it'll be 17 years soon. And I've taken care of hundreds of women. And the more you get to know them, the more you realize that each one's different and each one's valuable. And in taking on this subject of rooming in, I wanted to address something that was really basic to the needs of a mother and a child. And actually it should be a basic human right. So today, I'm going to look at my objectives here, or my overview. So today I want to go through my objectives, I'll look at some definitions, some stats, and review the evidence for rooming in, skin-to-skin care, attachment, breastfeeding, and a little piece on epigenetics, and how to care for the substance-using mother and child, and some of the challenges and concerns that come with this care. And also I have some recommendations and future directions I think that we could go in. At this point too, I'd like to say that this presentation is not going to be pharmacologically or medically based on the management of the substance-using baby. Substance-using mother and substance-exposed child. There's going to be another presentation early next year that'll address these measures, these issues. Sorry. Okay, objectives. I want to establish the benefits of keeping a substance-using mom and baby together. And I want to discuss the clinical management of supporting the substance-using mother and her exposed infant, and to discuss circumstances that presently limit the standard of care. So I'll start with definitions because they'll be thrown around a bit in the presentation. So NAS is neonatal abstinence syndrome, but it's now been replaced by language that's more suitable, which is NOWS, like NOWS. It's called neonatal opioid withdrawal syndrome, because the syndrome itself is usually opioid based. And this refers to, let me see if I can get this right here. This refers to a drug withdrawal syndrome that happens to a newborn about 2 to 4 days after they're born. And the signs and symptoms, they include altered sleep, high-pitched cry, they're very jittery, tremorous, agitated, poor feeding, sweating, they have fevers, and that's all considered NOWS. Rooming in is very basic. It's the idea of keeping a mother and a baby together from the time they're born. Get it started in LDR and then just take them right into that room, and all the care and all the support can be given to both of them in that room. The other thing I'd like to look at, Adrienne, am I getting this? Oh, here, okay. The definition of mother. So in this presentation, the word mother refers to the biological parent who birthed the baby. And I want to acknowledge that gender doesn't determine motherhood, and there are people who give birth who do not identify as female. Okay, cool. So is this all on the screen? Yes, it is. So I want to talk about stats, and they've mushroomed. In the last 10 years or 15 years, opioid use and opioid use withdrawal within the prenatal realm of care has just mushroomed. In Canada, in 2015 to 2016, there were 233 cases of NOWS in BC. In Ontario, between like this 12-year period between 2002 and 2014, it was 16-fold, and it went from 46 in 2002 to 761 in 2014. How did I get rid of this? And infants that, oh yes, and there's about 1,850 annually, and they don't include Quebec in all of this. And the length of stay is elongated. So a normal baby, when a baby's born, they're out within 2 days, maybe 3 if it's a C-section, but babies can stay 14, 20, here it says 20 days, but it depends even more on the social circumstances of the young woman and the mother, and how stable the environment is they go back into. The USA has, more specific stats. It affects 5 in 1,000 births, and it's increased 5 times. And there's a lot of, in my looking through all the research papers, there's a lot of mixed reviews and mixed responses. Like sometimes it's 4, sometimes it's 6-fold, but all you know is that it's been mushrooming, and I think in some ways it's caught caregivers by surprise. Okay, got it. So let's talk about rooming in care. So it's this rooming in care, as I said, is keeping a mom and babe together in the same room. And it has become a standard method of care in the last, I would say, 20 to 30 years. Before that time, I don't want to date myself, but I was separated at birth. but before that time, moms and babes, there was a nice nursery and everybody was in a little row and they brought the babies for feeds. And then I would say in the mid to late 60s, when there was this kind of revolution of thinking, changing of thinking as it went on, it became more apparent that mothers and babies, for the health of both of them, needed to be together. So this is standard care now within regular, normal maternity settings. And they really do support breastfeeding and having a partner or a parent involved as well. But this is not standard of care for substance using women. They're separated at birth in most places. They're considered high risk, the baby. The baby is put into a NICU, neonatal care, intensive care unit, and then they're monitored closely for withdrawal symptoms. And as I go on, you'll see how this is kind of counterproductive or sort of detrimental to both of them. The World Health Organization guidelines for the care of the substance using mom and babe and substance using women have recommended, highly recommended, keeping the mother and baby together. And there are numerous research studies out there that all end up with the same conclusion, that the best thing for a substance exposed baby and a substance using mother are to keep them together. The interesting thing for me though is that so much focus is put on the baby. And I mean, I understand the legitimacy of it, keeping track of how the baby's developing in utero, keeping everybody safe. But this is a dyad, and they can't, real healing and real health have to come with both of them being together. That's where real change will happen. There are some successful programs, and how do I get back? Help me, that one. I'm sorry. I have, the Addictions Nursing Fellow has been a wonderful experience for me. It has not been a learning curve, it's been a climb. And I could only open my computer up to get emails before all of this. So I've gone leaps and bounds, even if no one else can see it. So I want to go to this one. Okay, so here Noel took this picture. So all the photos, by the way, in this presentation are done by a gentleman who has volunteered his time for the last 8 to 10 years doing the photographs of these women and their babies, and it's a free service, and he gives them hard copy and he gives them ways to take them home, and I have permission from the women in the pictures and from Noel to use them. The other thing is you'll see like this letter, and there's some artwork in the presentation. We on First Square have an expressive art therapy program, and I have permission to use their work as well. So there are, as I said, some successful programs. One is First Square, which has been around now. It'll be 17 years in January of the next year. And it's the only one of its kind. It literally was pretty much the only one of its kind in the world. It was kind of modeled after something that had happened in Scotland, but the women were never in separate rooms. It was one huge dorm-like situation or setup, but the moms and babes were kept together, and they had such good outcomes that Ron and Sarah and some of the others went and met with her. This physician in Scotland has since disappeared because of political reasons, but we are still going strong by the looks of it. I still have a job in January, so things are doing really well. And there's a lot that has happened there. There has been some research, and especially in the early days, there was some pretty sound research that if you take a look at any of the studies on rooming in, you'll see Abrahams et al. In all of them. So let's talk about the benefits of rooming in. The most obvious and the first one is the mother-infant bond. And it helps to fortify this bond and this attachment that happens between a mom and a babe. And it's not always magic giving birth, you know, it sometimes can be a tough go. So if you can keep the mother and baby together, there are things that happen between them. There are hormonal exchanges. There's things that the baby do even within the first hour of life that can determine how well the breastfeeding will go, and how well the mother will feel even about taking care of her child. In the rooming in, there's increased benefits as far as breastfeeding goes. The numbers are up. In one of the studies here, Grossman et al., he reported that when they took the babies out of a NICU setting and put them into a rooming in setting, and the rooming in wasn't necessarily a unit that was specific for the care of these women. They would set up places in peds or else in a birthing unit. When they would set it up, from 20% to 45%, there was that much of a jump in the number of babies that were receiving their food through breast milk, whether it was being pumped or breastfed, but it changed everything. It it reduces the need for medication. And quite basically, anecdotally, or from my experience, what I've seen, when we first got started on fur, and I'll kind of refer back and forth, but we had, I remember children that were very difficult to settle, and they would be in NICU or else they'd be on the unit. But when the mother walked in the room and held the child immediately relaxed. It was kind of what converted Dr. Thiessen when Paul Thiessen was in charge of PEDS at that point. And he was, I think he might have been a little unsure about how we were going to proceed, but they had a really tough child who was just not settling, and that mother came, and it was just different, and it directs the care. They have shorter length of stay, reduced need for meds. If they can settle in that mother's arms, you don't have to medicate them to put them to sleep, you know, or to help them settle. It just seems that this contact allows them to relax more and just to be less anxious. There's also decreased cost if you're not putting the babies in NICU and keeping them for 25 or 30 days. At Sunny Hill, before fur existed, that's where substance exposed babies would go to. And sometimes they were there for 3 months. And the mother was not always included. Quite often mothers, my perspective, I mean, this is definitely not scientific literature, but they were discarded. They were forgotten about once you got the jewel you wanted. There really was no follow-up for the mother. She wasn't included. But with this, with rooming in, there are also increased numbers of women who are going home with their babies. They're gaining maternal custody, and they're going back into the community, and they're going forward living in a normal life. I like this. This was compliments of Dr. Abrahams. Notably, otherwise well newborns with NOWs do not require critical care. They thrive with comforting environmental measures. Attachment. So rooming in sets the stage for attachment. You can keep a mom and babe together. And attachment is incredibly important for the development and growth of a child. Its purpose is to provide safety and protection, and it allows them to explore and to learn and to be creative as they grow older, and they develop that sense of trust in their environment, and it develops a loving and reciprocal relationship. That attachment builds the baby and builds the mother. It also plays a role in neurological development, and as I said, trust. Attachment in the substance using mom is a little bit different, because usually women with substance use disorder, they're at increased risk for insecure attachment. They come with histories. Pregnancy commonly reactivates sort of representations of their own childhood, and many of those childhoods were insecure, violent. There was parental substance use, abandonment issues. They were not secure environments. So, and then the infants who experience poor attachment they're known to experience significant long-term behavioral, psychological, and emotional difficulties. And what they found, well, it gets in the middle of the infant-mother bond and the attachment, but what they've found even in the non-addicted population through studies is that it's predictive of infant abandonment, abuse, and neglect. And so it's even more likely or more highly probable within the population that struggles with addiction. Sorry. I'm going to do this right. Just a minute. I got it. Okay. I went backwards, didn't I? Mm-hmm. Oh, well. Okay. I can go for it. Next one. I went that one. So one of the finest ways for a mother and a baby to attach is to keep them together. So if you can keep a baby together right from birth, all this lovely magic happens, you know. I mean, that's not very scientific, but it's true. So there's an hour after birth where the baby makes it to the breast, where breastfeeding ends up, if they can attach and latch and feed and then sleep, it just fortifies or builds on that breastfeeding experience. You get a good solid base. So skin to skin itself was once called kangaroo mother care, and it happened about the turn of the, I want to say the turn of the century. It's not the 1800s, but late 1900s, 2000. There was a lot of studies that looked at preterm babies, and they had been removed from the mother, put into NICU with all the pipes and tubes and everything that goes with it, and the care. And they thought of this great idea that why don't we see what would happen if we keep a mom and babe together? And the outcomes were wonderful. They were phenomenal. I mean, and they weren't that far off. Um, I don't know how big the divide was, but the outcomes were great. So they started to look at healthy babies. And what they found is that it stabilizes the newborn. It helps to promote physiological stability, and it reduces their metabolic needs. So it helps the newborn's respiration, glucose levels. It helps reduce hypoglycemia, warms the infant, and so they can maintain optimal temperature, reduces stress hormones. There's lower cortisol levels, regulates blood pressure, decreases crying, and increases that quiet alert state. So they've been looking at babies who are being treated for opiate withdrawal, and they have increased metabolic needs. They're very jittery. They have elevated rests. They're having a really hard time, and their skin-to-skin contact associated with breastfeeding may be one factor in reducing sort of the severity of it. One thing that is really important to remember is you can feed a baby many different ways. Breastfeeding, I'm going to talk about breastfeeding. It's not sort of, I mean, it's the gold standard, but there are other options as needed. But you cannot replace skin to skin. And so if you can keep that child skin to skin, all these wonderful benefits come from it. And I personally have seen babies settle just being put on a chest. Both the mother and the baby fell asleep. Where am I? So the maternal benefits, there's been some studies done. They're not here. Okay, I know them. Anyway, there's some studies done that have shown that there's been it's Feldman and Ankazer or something like that. Anyway, it's in my notes. But there is decreased depression, postpartum depression. There was one study that showed decreased postpartum depression with skin-to-skin contact. There's a better, they have a sense of well-being. They're very happy. They're quick to respond to their babies. It builds up their competence when it comes to the parenting process. And the whole idea of increased cortisol, decreased cortisol levels just decreases the stress. And a woman who breastfeeds, basically, okay, I'm on skin to skin, but either way, they totally relax. And so there's this oxytocin kind of rush. They just completely relax, and it's visual. You can even see it happening. So here's a little yummy baby. So Gray found that skin-to-skin care can be analgesic through a series of studies, through a study that for newborns. Breastfeeding. Okay, so I'm a little all over the map, but as I said, it's considered the standard of care, and we really do whatever we can to help support it because there's so many benefits. Quite often, the substance-exposed baby isn't given that opportunity, especially if it's scooped off the delivery room table and taken to NICU. Sometimes it'll stay with the mom for a while and might be able to have that initial little bit of colostrum. But there are numerous studies that support breastfeeding for the substance-exposed infant. And as I've gone through them again and again and again, it's the same outcome. I almost feel like I'm going to be repeating myself, but keeping them together, breastfeeding, keeping them in the same room. It's not rocket science. But there is a negative impact on separation too that can be considered. When a mom and a baby are separated, the baby gets really anxious. So if you're to move a baby into the NICU, then it's very important to keep that mother in contact with the baby as much as possible. Having a baby separated makes it more difficult to breastfeed. It's hard to show up every 3 hours. And when you're breastfeeding room to room, that baby may feed every hour, hour and a half. So it's very exhausting for the mother, and it's very discouraging. And to be quite honest, in some environments, it's not always very supportive. And so they may make the choice to be removed from the NICU. It's easier not to be there than to be there. And so there's this loss in the relationship. Breastfeeding and substance use. So through the World Health Organization and the BCCSU opiate use disorder guidelines for the pregnancy, breastfeeding is encouraged. It's highly encouraged in women who are on opiate replacement therapy. WHO basically said that it's not necessarily a contraindication to breastfeed if you're using substances, although they clarify it by saying oats or abstinence, but they don't push abstinence too much, is preferred. And they also suggest that if a woman is going to use, then to have another plan in place to feed the baby. And there's a whole way of doing this where you don't breastfeed, you pump and dump for 72 hours. And but at this point, even in talking to some of the physicians on FER, I actually made a phone call to find out exactly whether or not we personally allow breastfeeding and use. And it's hard to avoid because many of the women who come for care are not stable. And part of the job is to get them stable on medication. And in that place, there will be use intermittently. And the bottom line has been basically that oat or any kind of replacement therapy is preferable. And because we're not sure of the nature of the medication or the drugs that they're taking, especially now with fentanyl, you don't know exactly what's in there and you don't know what the half-life is. So it's discouraged if there's ongoing substance use. Although it doesn't always play out that way. There is, Patty, I need to go back. There is some research, or there's various research that feels that there's enough methadone or buprenorphine in the breast milk that it will help the baby with withdrawal symptoms, and it's both positive and negative. Ultimately, they've decided that there's not enough in there to make a difference for the baby's health, and because there has been, no, I won't go up. Thanks. Because there's been studies done, and when there's abrupt cessation, the baby doesn't go through withdrawal. There's no withdrawal symptoms. But it has also been postulated that now severity is mitigated by the very act of breastfeeding. So rather than the amount of medication in the breast milk. Okay, the benefits of breastfeeding to the substance exposed infant. So I've got this divided into four categories, but what it amounts to is when a baby is born and has been exposed to opioids in utero, the respiratory and swallow centers are affected, and it throws everything kind of out of whack. So they show prolonged sucking, fewer pauses, more feeding problems, and increased arousal. They get very, very upset. And what happens is there's a suck, swallow, breathing response, and they are completely uncoordinated. They cannot suck and swallow, and there is no regulation to it. There's also a syndrome, or I don't know if it's a syndrome, but it's called hyperphagia, and they tend to overeat. And it can be more pronounced when formula is given to the baby. But they will eat and eat and eat, and I think they think it's in response. The study has said they feel that it's in response to the fact that there are increased needs for calories in withdrawal. So they're trying to make up the difference, but it makes for a very upset stomach, and it makes for a very unsettled baby. and they are looking at breastfeeding as a way of regulating this, because if you respond to the infant's cues, the feeds are shorter, the breast milk goes through the system faster, there's less GI upsets, and you can also comfort feed to help the baby settle. The other thing that was interesting, oh well, I'm a work in progress. The other thing that's interesting is they have found that breastfeeding or breast milk helps to develop a healthy gut microbiome. So that might be of assistance, or it's an assistance in the GI problems that a little one has. And I mean, and there's parallels between an adult going through withdrawal and a baby going through withdrawal. So they struggle with many of the same issues. I didn't say it earlier, but when I speak about withdrawal, it's opioid related. But I want you to know that what is offered here is, it should be available to whatever substance the baby's been exposed to. And I mean, it has the same benefits, but withdrawal specifically when we treat it is opioid withdrawal, because there are no other specific treatments for any other kind of exposure except the comfort measures. Here. Okay, and maternal benefits. In the studies that I looked at, I found that there's a correlation to a possible increase in the development of diabetes and cardiovascular issues in time, but there's also an increased risk for breast and ovarian cancer. That's what some of the studies had put forward. Compared to women who formula feed, women who breastfeed have a higher levels of oxytocin and prolactin, and as I said, lower levels of cortisol. And this may help decrease the anxiety and stress that comes, that women with substance use disorder experience. And we have to remember that having a baby and being in this situation isn't just about the baby, it's about a whole lot of other factors that we'll look at. So this will help them relax and settle. It also, the act of breastfeeding, this is really important actually. The act of breastfeeding her own infant may also help a mother with her feelings of guilt when she sees how it calms her infant and helps decrease the neurobehavioral difficulties with NOWs. And that really is an important point, because many of the women that I've seen really struggle with feelings of guilt and helplessness if their child is really struggling with withdrawal. Okay, I'm hoping I can pull this off. I want for just a few minutes or less to talk a little bit about epigenetics. And I'm not sure if you've heard of it before, but it's basically the study of how genetics interact, genetics interact with the world. This is going to really be like kindergarten basic epigenetics, but it's really very, very exciting. So the DNA wraps itself around the cell, and on the DNA, markers form. And this is what the study of epigenetics is. It's a biological response to an environmental stressor. And it doesn't change the DNA, it just changes the expression of it. So, and these little tags are chemicals. And they can have a marked influence on a person's behavior. They did some studies with rat pups, and they tend to form due to stressors. This is a new piece of scientific study, and it really is exciting. And why it's exciting is how it can affect or possibly affect the women that come to us into our care. So there was a study with rat pups, and what they did was the licking and grooming was the care or the contact, and some had more, some had less, and then they removed them from the mothers, and they would freak out. They would fall apart and they would respond to stress. And there were like chemical responses too, like they were taking blood from them and checking. When they put them back with their mothers, the process stopped. And but if they were left to continue to live like that, they had an ongoing lifetime response to stress that was more frantic. They didn't respond well to stress. So the reason I'm looking at this is, let me see if we can do this right, is something called transgenerational trauma. And within the population that we serve, I would say our stats on FIR, 70% at least of the women that we serve are Aboriginal. And it's been found in studies that this transgenerational transmission of trauma refers to a traumatic experience that happened to the first generation, but it's passed on. So it leaves a chemical mark on a person's genes, and it's passed on to subsequent generations. And in the literature, you can see it everywhere. They're looking at this in terms of other studies as well, but in the literature, when you can see sort of the impacts of it. And what I'm suggesting, and what are they're suggesting too, is that there's a way to halt the process. So that if you could keep a mother and baby together, you could, babies don't come with a lot of markers. They have some, but they can be turned on. So if you look at it in terms of an Aboriginal woman who's giving birth, whose mother's children were taken, whose grandmother's children were taken, and in some cases great-grandmother's children were taken, there's a possibility the process can be stopped and you can go forward. And to me, that's incredibly exciting, because if you take care of a child and a mother, and they have this future in front of them that won't be tainted in the same way. Anyway, I think I got that, what I wanted to say. But when you look at the 60s scoop and you look at the amount of children being removed at this point, my next slide is, okay, it's this. I bring it here, I bring it here, I go there, and then I go there. Yes. This slide is incredibly powerful. A very good friend of mine is a social worker, and I phoned her yesterday at the very last minute and said, I want to know what the removal rates are for Aboriginal children. 46% in 2018 of the children that were removed and put into care were Aboriginal. If you go back to 2007, it was 63.5%. I mean, it's heartbreaking. And you can't, I don't even need to say anymore. I just think that that's incredibly powerful. And if there is a way to move forward and break the cycle, I mean, real healing, could happen. Oh, and I went too fast. Okay, so the care of the substance exposed infant, we talked about it. Rooming in, skin-to-skin care, breastfeeding. And then what we're using now, we're incorporating, is something called Eat, Sleep, Console, and then we do weights. Because weights are very important in all of this. If they're losing weight, they're having a hard time with withdrawal. So you want to make sure that they can get past that point and go forward. So let's see, how do I do this again? Wait, it goes there, goes down. So this is our non-pharmacological treatment. And it's interesting, the people who developed this were the people from New Hampshire who came to hang out with us for a week on FIR. And they went home and took all this information and created this lovely guide that you can use. A recent study demonstrated that observing infants' ability to feed, sleep, and be consoled is an effective method for assessing NOWs, leading to fewer infants requiring pharmacological supplementation or any kind of medication. And then we also provide pharmacotherapy as needed, and we work the care of that. You work hand in hand with pediatrics. Let's see. I'm going to do this right. Okay. And then there's the care of the substance-using mom. So usually, if the mother's on opiate replacement therapy, or if the mom's on opiate replacement therapy, you continue with the management of it, and you can just continue to support the breastfeeding and the skin-to-skin care, offer the culturally sensitive care or supports that they need, and it's really important to maintain a positive connection. What you want to do is create a relationship that questions can be asked in, people can get frustrated and express their frustrations, and that you can support them to move forward. It's important to remember, this is really important to me, that many of the women that come who've been substance using women have never raised a child. They may be gravid for, this is their 4th or 5th pregnancy, but they've never had a baby to take home with them. So it's important to be sensitive to what kind of care they need, and to hear, like, something as simple as putting on, changing a diaper, or giving a baby a bath. These are the things that you support them with, and these help build relationships. So, because there are other issues that happen. As I said, there are attachment issues for the substance using woman when she gives birth, but a lot of the past comes up, and there's always a possibility that there'll be struggles with depression, or past PTSD will show itself. So if you can be sensitive to the care of the woman, you'll be able to find the supports that she needs, and to help follow through in the community as well. But it all has to start in that rooming in place. It all starts where confidence and relationship is built and created, so that you can go forward. So there are factors that limit the implementation of this evidence-based care. There must be many, because there's not very many people out there doing rooming in. And it doesn't have to be a big ward with a whole lot of hospital supports. There are places that they just make room in on a postpartum unit, or if it's more appropriate, they do it in peds, but they work very hard at keeping a mom and babe together. So stigma is one, and there are challenges for the mother. There's a need for caregiver education. There's a great gap in understanding amongst many caregivers. And then there's also childcare services, which is also limits implementation. I want you to just look at this. Can you read that? Can you see what's being said on there? How clear is that? This is some of the artwork from one of the women on fur. And one side, I think it's about a quarter or less of the head, is who I am. And the other is what they see. And at the bottom, it says, if everyone would see through my skin, I could contribute to society again. And this is really heartbreaking, because as I was going through the artwork, there were lots of these. There were lots and lots and lots of these expressions of feeling less than, feeling like other, feeling like they need to disappear, that they have no value. And I found this quote from one of the first studies that Dr. Abrahams did. And it was, separation is generally based on 2 assumptions: that the mothers involved are incapable of being good mothers, and that the management of withdrawal for these babies is safer when they're not in the care of their mothers. And these women themselves have had difficulties with the healthcare system in the past, and they have their own issues with trust. So there are bridges that need to be built, gaps that need to be filled. Moms have challenges. As I said, there's issues of trust, their own personal trauma. Many of them have had numerous losses. Honestly, I have had, anecdotally, I've had patients that come and they've had 5 or 6 children and they've never had the opportunity to mother them. They struggle with low self-esteem. And there's also the possibility of whether or not they're ready to parent. So as I go through all of this, it looks pretty good, you know, like we've got all these things to offer, they can do it. But what if they're not ready? What if they're not ready? Because there are a lot of internal struggles, emotional struggles, you do what you can to help them have contact with their child. If they can't room in and it's just not working and it's not safe, then when it is, bring them together. As long as it's a safe environment. We have a nursery, so we can on fur, and there are other nurseries, and there are also services offered like volunteers and cuddler supports. So there are ways to support a mother while, you know, she has has her baby, and also honor the fact that this is where she's at. Regardless of how solid evidence-based practice is, we're dealing with a human being, and we're dealing with for me, I'm dealing with a broken child. You know, we have no idea where this person has gone to, what they've had to do to get here, to the environment that the caregiver's at, and they're giving birth, and we have no idea how foreign this is to them as well. So it's just a matter of honoring that. So, healthcare provider education. I did make a statement yesterday. Until I started the Addictions Nursing Fellow, okay, I've been on FER for 16 and a half, at least 17 years. Holy crow. But anyway, I didn't know what I didn't know until I left. I didn't realize the gaps I had, the information gaps, how much more there is out there, how to pull it all together. I feel so privileged for this opportunity. And so offering education, there's huge gaps when it comes to understanding substances, how they work, withdrawal. I mean, this is in the general population, it's in our general hospital population as well. And we need it especially in perinatal obstetrics when we're dealing with this. And there's a lack of understanding of trauma and what trauma really is, and the brain changes that happen, and how our role is. We cannot expect from something from someone that they're unable to give, and so understanding trauma at least allows you to understand why they're never on time, because they can't, you know, I mean, it's incredible. Like, there's a great book. Anyway, education. The other piece, this was quite interesting, I thought. It was a quote that said, "Only when nurses hear the stories," why am I not getting this? "Only when nurses hear the stories of substance-using women will they expand their understanding and empathy for the women's struggles. The nurse might then be able to provide support for substance-using women who may be struggling to develop healthy relationships with their children." And I have seen stories change caregivers' lives. That's where empathy comes from, and that's where understanding comes from. And this is the last. I don't want to say the best to the last, but this really is an issue. This is a really powerful factor as a limitation, and it's government child care services. So many of these women have had numerous losses, and when they come into care, they're very afraid. The environment's not familiar to them, but they're very afraid of what can happen because they're very aware of where they sit in life. The fact that they're using, they have no home, they have no money, that they've been a child in care themselves. And many of them have had a history of ministry involvement. So this is a very sensitive, and there's no clean answer. You tread carefully. You tread carefully. We have no responsibility to report a woman's use when she's pregnant. And then to go forward, you would probably work with a social worker or to make that step forward, because there is a responsibility then if it's considered an unsafe situation. So it's something that you'd really have to look carefully at, and it's important not to report too soon, and never to report without the knowledge of the woman that you're caring for. Her voice is incredibly important in all of this. If it may be your responsibility to report, but she needs to be a part of the story as well. What has been encouraged is that a conversation happens between the ministry office and the young woman when she's pregnant, so you can start to build up a relationship with them, and possibly a relationship of trust. And it's much better than having a baby and coming in cold and they have no idea of your history or what your strengths are. Where am I? My recommendations: provincial strategy. We have a model of care that is in the process of being worked on and coming out as a 3-year project. And it's just a matter of us all getting on board. There should be, with it, clear clinical guidelines, and we need some champions. We need people to go out there and try it and mess up and go with your heart first and your head right on top of it, you know. It's just do the work. I mean, there's many women that have come that I've had the privilege of taking care of. And I remember coming in and getting this great report that told me I had somebody who'd been in jail and who was using and who'd done this and had done that, and there's domestic violence. And I mean, I thought, oh my God, what am I going to run into? And I go to the room and there's this sweet little girl sitting on the bed. So create relationships. They need us. Educational programs, just enhancing evidence-based understanding of substances and substance use, so you have a good solid understanding of it, and also, you know, how to help them keep safe. Trauma, culture-informed practices, and then just have the perinatal education in line with the provincial model that's coming out. There's a great model of care coming out. And future recommendations, for me, I like to be able to follow up with the women after discharge. Many of them do not have the opportunity to go home with their child. And as I've been on the streets, I've been running across some of my clients. And I'd like to know what the holes in the fabric are. And I think it would be really good, solid information to go forward with. Nursing perspective, that's another thing. We could look at the challenges or concerns that we struggle with, or even caregivers in general, to how to make this work, and addressing the gaps between the hospital and the community, measuring the outcomes. And so here's that baby, and that baby is they did a plaster of Paris model of her belly. And after the baby was born, they took a photo of her inside her mom's belly, outside. And that letter at the beginning, the mom wrote a letter back from the baby to her, and she called it "Mommy's right here." It's okay, no need to cry, because Mommy's right here holding you tight. Just close your eyes, my sweetie pie, because Mommy's right here, right by your side. Now wipe your tears, nothing to fear. Mommy will always be right here. Thank you.
Thanks so much, Patty, for that wonderful presentation. We have a few minutes for questions if anyone has a question they'd like to ask Patty. Yes.
Thanks very much for the presentation. You mentioned that there's a new provincial strategy coming up. Is there anything you can tell us about it? It sounds like you're looking forward.
My understanding is the government is supporting, it's a 3-year project, a provincial strategy to roll out the model of care province-wide. And we've been working on a model of care itself, a module that is just about ready to be published. So I was part of the process, and I just saw the last copy, and so they're still going through the stages before they'll publish it. And it'll be really good, solid, basic guidelines that no matter whether you live in Bella Bella or you live in Kamloops or, you know, on the island, you'll have a place to go to. I'm hoping that they will create some kind of contact line or a way to mentor people too from different areas, so that if they're just not knowing how to proceed or how to go forward, that they could ask questions and find areas of support. So, hi.
Some of the problems with the demand is that first is designed with the central nursery to respite of moms. How can you imagine respite of moms to happen in a place that does not have a central nursery such as St. Paul's? Are there any tips that you can give us for bringing in?
I don't know what other resources you have. I know it's really hard. I think I'd work really hard at keeping a mom and babe together on the unit, but it's and like we have central nursery to give a break. So we really work hard at trying to keep them together. And and they need supports. So I don't know what kind of supports you can put into place. Whether you can, I mean, it's an abuse of the NICU, but I mean, if there was a way to, you know, if they needed a couple hours, you know, to sleep, because I know that's really an issue. Like a rooming in mother can't always room in completely independently. They need breaks. They need, you need to be there to monitor too. Sometimes they fall asleep with their baby. They may not be ready to parent full time. So yeah, I'm in a really privileged position, you know, but if you could find supports in the community, if there was family supports, if they had like a partner that could be there and that could, or a mother that could come and help out, and probably maybe the more formative days, like at the beginning. I'm not sure how you get things like people like doulas, or because there are people that I'm at a loss. I'm at a loss because I know how hard that is. But they've done it in New Hampshire. They don't have a unit, but they've done it on a postpartum unit and in a peds unit. So they somehow created a caring environment that would compensate for those needs. But that's not much of an answer.
Can I ask one more follow-up question?
Yeah.
What is the nursing ratio for you guys on birth?
We have 12 beds, which could be a mother and baby. So that would be well, I think the new unit has 13, so that means, so that means you can have anywhere from the 13 to the 26 clients, and we have 4 nurses on. So it's not a bad ratio at all. But if you have the nursery, then you only have 3 on the floor, and you have the nursery, and the nursery can get pretty busy sometimes depending on what's going on. So, hi. On birth. They don't like to take them too early, but because I mean we've had them at 15, 16 weeks. Part of the issues with gestational age is many of them are homeless, and there's a misunderstanding that fur is a way you can move in. You can just move in for 3 or 4 or 5 months, and then you give birth and you can stay there for a couple more months while you're at it. So they're kind of trying to discourage that, because the length of stay was like going through the roof. But you also, if you have someone doing well, you don't want to put them back out on the street, you know. So what we try and do is connect them with resources in the community and wait till it's a little further along. It depends a lot on their stability too, because in a perfect world, you could bring and it was like this at the beginning, ironically. You could bring a woman in, keep her for a couple of weeks, help her get stable, put her back into the community, see how she does in the community, whether it's in a shelter or some kind of housing. And it's not working, she can come back again. We used to call it the revolving door policy. We don't do that much anymore. But it allows them to get stable in the community and to learn how to live in the world, because they can become institutionalized sitting in that hospital, and that's not doing them any good at all. We're done. Thank you.
Thank you.
I talked to you on midnight.